Great, thank you, Angela. And I'm going to also start with a thank you. My presentation is going to be focusing on the strategy and just giving you an overview of the strategy, and also I'm going to spend a little bit of time talking about the data and the context, and it wouldn't be public health if I didn't throw in a few charts and graphs. So that's what I'm going to be doing. But I just wanted to say a huge thank you. The strategy has come about with all of your support and effort, and I do want to particularly say thank you to the CHAMP support team for all their leadership and direction around this. I know for Hitch as well, who've supported all the design and the engagement, and all the partners, and particularly the Lived Experience Network. This is the first time I think in this strategy that we've had so much artwork and poetry and other things to bring the strategy alive as well. So big thank you to everyone, because many of you have contributed from this room to the development of the strategy and its contents. So what I'm going to talk about is I'm going to go through some of the national data, so the Office of National Statistics. Then I'm going to be looking at kind of what's our real-time surveillance. So this is a tool that we've developed here so that we can get data very, very quickly and act on it quickly. Then I'm going to talk about kind of the context of the strategy and keeping the focus on suicide prevention. And although suicide is a hard thing to talk about, it's so important. It's so important. And the work that everybody's doing, it does make a difference, and that's why we're here today. And then I'm going to just give you an overview of some of the key points of the strategy. And I'm hoping I'll whet your appetite so that everybody will go away and read it. And the last thing we want is a strategy that's sat on a shelf somewhere. It's designed to be something that engages us, helps our thinking, and really shapes our action over at least the next 5 years. And so this is why we're really grateful for all of you coming today and engaging with us on this. So I'm going to just be talking about some of the statistics. Now, just to be aware that there are some delays in recording for the statistics from the Office of National Statistics, because it's based on coroner's reports. So that does affect some of the recording, and I'll talk about some of that as I go through the presentation. And again, our real-time surveillance data might look a little bit different. So you might see a difference in the figures between the national statistics, the official statistics, and ours. And that's because our real-time surveillance collects slightly wider data, if that makes sense, and also with the reporting. So don't get worried if you see a little bit of a difference between the statistics. And just to say that we've done up to 6 months, so the data for our real-time surveillance is up till the end of June. So this first slide shows you Cheshire and Merseyside on the top level. Don't worry if you can't see it all, I'm going to talk it through. And on the bottom level is England. Now what you can see, if you look at kind of from around kind of 12 to 14, those 3 years, you'll see the impact of the recession that we had. Now, just so you know, in terms of the suicide statistics, because of the statistically small numbers, everyone is too many, but in terms of statistics, the small numbers, we tend to do them as 3-year averages. And you'll see that the results of the recession took a couple of years to impact suicides, but that's what we saw drive an increase in suicides, both nationally, but particularly in Cheshire and Merseyside. And you'll know that from some of our boroughs suffer more with deprivation, you know, the North East and the North West. And so we saw some of the bigger impacts. But you can see why then we really realised more than ever, we had to make this a priority. And I think this slide indicates that we had some impact, because you can see that in Cheshire and Merseyside, the number of suicides continued to go down, where nationally it was going up. So, you can see that actually having a focused effort made a difference. And this is the data up to the pandemic. So this slide now looks at it across single years. So that the last one was 3-year rolling averages. This is across single years. And what you can see is that there's apparent big increase in 2021. But we think quite a bit of that was recording issues, if that makes sense, because of the coroners, unfortunately, with the pandemic and everything else. There was some delays. So we think there has been some increase, but it's not quite as stark as that. But you can see why we need to continue to look at the data and why having our real-time surveillance data is really important. And it just gives you that kind of pattern. And this is going back all the way to 2003. So you can see that one across Cheshire and Merseyside. This one shows you kind of over the last, kind of back to rolling averages again. So we've got 2016 to 18 in the lighter green, 2017 and then 18 to 20, and then 20. The latest data is up to 2021. And I think what you can kind of see from this slide, you can see St Helens sticks out there, doesn't it? And you can see why in St Helens we wanted to have a strong leadership around suicide. And I thank you to Sue, who was leading on that before me. And you can see why St Helens had really high rates. But you can see across the patch that there's been a little bit of change. And you can see that the numbers looked a bit less in 2018 and 20 and have gone up. But again, some of that is that artificial just because of it, of not all being recorded. But you can see some areas, there's a little bit of an up and down, but you can see the general trend for England and the northwest is an increase, and the northwest has increased potentially a little bit more. And you can see some areas, again, various Cheshire West and Chester look like they're beginning to see a little bit of an increase. Liverpool also as well, whereas Wirral. So you can see there's a little bit of difference across the patch in different years. Again, this shows you, this is now our real-time surveillance. So this is not the Office of National Statistic data. This is our local data for 2020, 21 and 22. And on here you can see this one is by number. So in some senses this is affected by the population. So Merseyside has a bigger population, so you see there's a little bit of a population aspect. But you can see that according to our real-time surveillance data, 2021 was when we saw a big increase. And one of the things that we think was a factor for us in Merseyside was the impact of the pandemic. So you probably know that Knowsley, Halton and St Helens are in the top 5 in the country, and actually Merseyside as a region has been one of the hardest hit impacts. And also Merseyside was in restrictions much longer. So we think that there is a pandemic effect that's affected the number of suicides. Our data for this year is showing that doesn't seem to have continued. It's still a little bit early yet, but our figures does seem to see that was a bad year, but actually it doesn't seem to have continued, which was our big worry that we were going to see that trend, but thankfully it hasn't continued. This just goes to show you by area again. Now again, Liverpool is a big city, so this is numbers. So there is an effect by numbers. That's why in some ways Liverpool is at the top. But you can kind of see, particularly in Liverpool in 2021, the number of suicides that they had there. Again, Wirral, Sefton, St Helens. And you can kind of really see the Merseyside effect, because Cheshire actually in some areas had less that year. So you can see that the impact in Cheshire and Merseyside in 2021 was predominantly delivered through what was happening in Merseyside rather than Cheshire. And again, you can see kind of the trends, but we were watching Cheshire West and Chester because they had an increase, it seems, at the start of the year. Again, it's small numbers, 1 or 2 can make a difference, statistically small numbers I'm speaking here, but it just means that we're really monitoring very closely to see what's happening in those areas. So again, this is our real-time surveillance data by month. And this is helpful because there are some patterns across the year with suicide, and it might not be what you think, because actually spring generally is when you see an increase in suicides. A lot of people would be thinking it was kind of after Christmas, but it tends to be kind of in the springtime. And you'll see that kind of when you look at the kind of the 2019, if you look our highest number, I'm going to try and see if I can shine a light on it there, was in May. But then in the following year, you can really see the pandemic effect. And again, what you can see kind of looking at the blue line is that actually when we were all in lockdown, suicides were less, but it was when we started to come out of lockdown in the July that suicides went up. And again, in 21, we do see a little bit of a time difference again, which we think was due to the pandemic effects. And then this year, again, we're beginning to kind of go back to the normal type of pattern that we would see. So we do look at the data by months as well. I know we were talking, I think Neil was talking about this already, and this kind of figures just gives you the breakdown by men and by women. So you can see green for women. Oh, sorry, wrong button. And it is still around 25% are women and 75% of our suicides are in men. And that pattern is continuing. I've just looked again, just checked the numbers, and it's around 25% for women and 75% for men each year. Now, one of the things within our real-time surveillance data is that we can look at more detailed records of people's notes and understanding their background, and so we can get a lot more data from our real-time surveillance just than the statistics that I've showed you as well. So we can get kind of an understanding of some of the kind of patterns and the behaviours leading up to somebody's suicide. And one of the things that we've started to record is history of self-harm, and we're still developing this measure, but we've now got that recorded in over half of our cases, whether or not we've got that data. So we know in half of our cases the data. And I think what was possibly worse than we thought was that 58% of those where self-harm is, of those recorded, 58% had a history of self-harm. So that was quite powerful to us in terms of really having self-harm as a focus within our strategy. Some of the kind of things I just wanted to talk about as well is I know we're launching our strategy today, and it's a relaunch in some ways because actually we've been working on this agenda for quite a number of years now, and really I think this is our third strategy refresh. And so I just wanted to highlight, and I know Neil and Tim talked about some of these as well, but some of the kind of things that we've done, in terms of actually impact, we have managed to reduce the number of suicides in Merseyside prior to the pandemic from 248 in 2014 to 207 in 2020. And again, obviously we know there's a pandemic effect, but we were able to make a difference we've looked at that. We know the efforts that we put in do make a difference. When you have a focus, when you work together, it has an impact and it saves lives. So, we do know that what we're doing has made a difference and will continue to do so. I think just some things as well, we've had our Amparo Suicide Liaison Service, and to think we've got the Staying Alive app and other resources that people can access, and we've encouraged people to download and have access to those. I know we've got some talks later on some of the men's health initiatives, so I won't talk too much about that. But again, a lot of work, about how to have the conversations and thinking about men and how we get men engaged in services who typically might not attend. Again, I know Tim and the others in terms of the mental health trusts as well have managed to get the safer care standards, and that includes things like safer wards, 24-hour crisis teams, family involvement, staff turnover, also, alcohol and drug misuse, history of self-harm. So all of those standards are in place when people are receiving care. And one of the things, we've got members of the Lived Experience Network today. And again, very, very valuable, just being able to talk to somebody who's been through what you're going through. It's invaluable, isn't it? And so pleased to have the network right across the patch as well. So I'm just going to talk a little bit just about the strategy itself. This is our vision. It's not necessarily our target, and I think there's a difference between having a target and an aspiration and a vision. But this is our vision, to be a region where all suicides are prevented. And this is the clear thing as well, where people do not consider suicide as a solution to the difficulties they face, and where we build hope. And Angela was talking about the importance of building hope. In terms of our mission, resilience, because actually we want to stop people ending up in a situation. So we want to build that resilience. We want to kind of focus on keeping well, supporting people. You know, no matter what we do, sometimes people just end up in a crisis. We all know that circumstances can change very, very quickly. Creating an environment where people know where the help is and how to get it. And also just about that safer communities, which I alluded to earlier. And again, just tackling the risk factors, you know, putting the services in place. We know what a lot of the risk factors are, so it's thinking about those as well. Our values, again, health and inequalities. This is about making sure that we're getting services to those who need them most. Reducing stigma, so important a lot across the whole of mental health, that we reduce stigma and that people can be taught and talk and be honest about how they're feeling. It's about people and place, so it's about persons and also thinking about communities. And collaborative working, you know, I can't emphasize how important that's been. Data-driven, and, you know, we're making it because we're looking at what the data's telling us, and systems leadership. And I know already that Neil has talked about kind of what the priorities are, so I won't go into these. I know we've got a presentation on each of those. And I just wanted to say that although these are 4 priorities, these are because these are the ones where we think we can make the biggest difference. But that doesn't mean we're not going to be doing lots of other things as well. So I just wanted to give you that assurance, you know, working on drugs and alcohol and other bits of strategy and all sorts of things. But these are the areas we're focusing on together where we think we can make the biggest difference. And I think just in conclusion, really, what I want to emphasise is I think now more than ever, we need to focus on suicide prevention. I think the difference with this cost of living crisis and what we've experienced before is I don't think, obviously there was a time like of kind of about 3 or 4 years before the impacts of recession, but I don't think I think we're already seeing an impact, and people on the front line are already telling me that people are talking about suicide much more already, and people are at crisis points already. So I think this is the time to really focus on that and to think about the cost of living impacts. We need to be action orientated. And, you know, Angela talked about hope through action. And again, the strategy is about giving us a framework, giving us some guidance, giving us some key pointers. The next bit, this is where all the hard work starts. It's now putting the actions in to back up that strategy and to make a difference. Thank you very much for listening.